Good afternoon, everyone, and welcome to this Traffic Safety Hot Dish. Today, our topic is traffic safety lessons from Washington State. I'm Catherine Diamond. I'm the moderator for today's session. I'm the interim section manager of the Injury and Violence Prevention section at the Minnesota Department of Health, and also co-chair of the Minnesota TZD and the new Advisory Council of Traffic Safety. And I'm excited to be here for this great conversation. We want to thank our sponsors or our hosts today, the National Highway Traffic Safety Administration, Minnesota Department of Health, Minnesota Department of Public Safety, and the Minnesota Department of Transportation. A couple housekeeping things. This webinar is being recorded. All attendees are muted. You'll be able to find several useful items on the Minnesota TZD website after today's webinar, including PDF copies of the speaker's PowerPoints, a PDH form for continuing education credits, and a recording of today's event if you want to rewatch or share with others who maybe couldn't join us today. Video and audio of all participants is turned off for now, but you can communicate with the speakers or other participants using the chat and Q&A boxes at the bottom of your screen. Please use the chat feature to introduce yourself, share ideas with all participants, or to let us know if you're having any AV or IT issues. There'll be a couple of times throughout the presentation where we prompt some discussion and ask a few questions through the chat box, so please share your ideas. We encourage interaction and discussion through the chat. And please note that you can send to all panelists or send to all panelists and attendees. So you can decide which you want to use when asking your question or making your comment. Use the Q&A feature if you have a question for our speaker. I'll keep an eye on that chat. And if it's relevant and easy to answer in the moment, I may share it with the speaker at that moment, or we have time at the end for Q&A, and so we'll save it until then. I'd like to introduce our speakers. Today we have two great speakers. Our first is Shelley Baldwin, Director of the Washington Traffic Safety Commission. Shelley is a pioneer in applying proactive traffic safety culture to an innovative statewide campaign called Together We Get There. The campaign moves away from fear-based messaging, instead emphasizing steps all people can take to make our roadways safer. Ms. Baldwin has 25 years of experience in traffic safety, strategic planning, communications, legislation, and preventing impaired and distracted driving. She serves as a co-chair for the Governor's Highway Safety Association's Equity and Engagement Committee. Our second speaker will be Dr. Max Roberts. Max Roberts is the Senior Research Associate at the Washington Traffic Safety Commission. He manages the agency's data dashboards, conducts research and analysis for trends in traffic fatalities and behavioral traffic safety in Washington, and provides technical support to partners and stakeholders. He also manages the research grant program supporting grantees to produce new research to promote traffic safety. He also serves as a member of the Research Committee for the Governor's Highway Safety Association and as a member of the Transportation Research Board Standing Committee on Impairment in Transportation. And now I will turn it over to Shelley as our first presenter.
All right. Okay. All right, I think I did all my buttons. If it doesn't look good, somebody tell me. Good morning. I'm Shelley Baldwin. I'm the director of the Washington Traffic Safety Commission. We're very excited to have been invited to be here. And today I'm going to talk about our state strategic highway safety plan, which all states have and keep updating. We're about to do a really major update. And what I'm really going to talk about is how we're rethinking the whole plan rather than just updating it. The Washington Traffic Safety Commission is an independent government agency. We sit on the governor's cabinet, and the governor is the chair of the commission, and we have a total of 10 commissioners that represent all agencies, state agencies involved in transportation, from the Department of Transportation, State Patrol, Licensing, Department of Health and Healthcare Authority, Superintendent of Public Instruction. And we also have 3 members that represent the judiciary, the counties, and the cities. So it puts us in a great place to do amazing partnership pieces. Our agency recently went through a new strategic planning process, and we're really happy with what we've come up with. We've been a Target Zero state since 2000, and Traffic Safety Commission participates with other partners to reach our goal of 0 traffic fatals and deaths. Our vision is a Washington where we all work together to travel safely on our roadways. And our mission is to empower and equip people and communities with knowledge, tools, and resources to build a positive traffic safety culture. So the plan, we've had a plan for, a really long time, since 2000 actually. And the plan was originally developed as a toolbox. So we worked very hard to get all possible strategies and research and everything to bear on each focus topic that we had, so that anybody who wanted to improve traffic safety could pick up that plan and figure out if there was a strategy that would work for them. It's been a great plan. I'm really proud of it, but a lot has changed in traffic safety, especially recently. And it's hard to implement a toolbox. So we have refocused our plan on 3 pillars. We want it to be implementable. We want it to be smaller. I think our last plan was probably close to 400 pages long. We want to design it so that anybody can get to the parts they need. It may not be so much as a printed document as something that lives on a website and gets updated pretty regularly. And the new things that have been really coming down the pike in traffic safety, at least for us in Washington, is really adopting the safe system approach. And that is, I'm not going to go into it deeply because I'm assuming most of you have heard of it. If not, USDOT has some great information about the traffic safety approach. But we're going to be adopting that as the framework for the plan. 2 of the principles that come out of that framework are responsibility is shared and safety is proactive. And that leads really nicely to what the work that we've been doing in proactive traffic safety culture. And everything we do is really centered on racial equity in Washington. And, deaths and serious injuries are unacceptable. And that equity piece really says for everyone. And different groups have different cultures, and every community has strengths. So this is going to be the basis for how we build our plan. It's different than we've done in the past, and I'm really excited about it. It's been difficult because there's not a recipe for us to follow. This is really something we have to mold as we're doing. So to start with equity, the first thing that we've been doing in equity is really using our data to identify underinvested communities and overburdened communities, so that we can do a better job reaching out and making sure it's community centered with our programs. So to do that, we used a social vulnerability index. Part of our Department of Health has this. And you can see it looks at many different factors of what would make a community overburdened: household composition, disability, socioeconomic determinants, housing types and transportation availability, and race, ethnicity, and language. So when we put all that data together in Washington, this is what that health disparities map looks like. And the darker the purple is, the more disparities exist. And it's hard to see without really zeroing in, but there's a Yakima County that has a reservation, has a lot of disparities in the whole county. It is the highest number of Hispanic and Native American fatalities for the whole state. And then you can't really see in here in Puget Sound. I guess I'm not showing you. In Puget Sound here, there are pockets of really, really dark purple things going on. So that helped us identify really Yakima and South King County as the areas that we wanted to focus on. So the next thing we did was make sure that we were listening to those voices first before we even started building the plan. We worked to contact 50 different community-based organizations to see where we could align what they were doing with interest in what we were doing. We conducted 4 listening sessions with stakeholders in those areas. We visited fairs and festivals and other community events to just kind of lightly survey people. The surveys were really interesting because they had set up a goal to get X number of surveys, but they found once they started talking about traffic safety, people wanted to talk a lot. So each survey took longer than they were thinking. And I think that's an important thing to remember, is that traffic safety really does impact all of us. And we held a separate tribal listening session. It was fascinating and eye-opening to listen to just the differences in what they experience being on a tribal reservation compared to what the county around them experiences. So the safe system approach, I'm sure that you have seen this before. It really focuses on developing enough redundancy in the system, looking at road users and safer vehicles, safer speeds, safer roads, and post-crash care challenges us to make sure we have as much in place as we can so that all that redundancy prevents a fatal crash from happening. In Washington, we've looked at the principles. We have a slightly different set of them. They're similar, but Washington always wants to do its own thing. So death and serious injuries are not acceptable. Responsibility is shared. Safety is proactive. We want to support safer road use and reduce crash forces and strengthen all our parts together. So what does that look like in Washington other than our plan? Well, it's a direct executive order from our Secretary Roger Millar, Secretary of the Washington State Department of Transportation, saying that they're going to advance the safe system approach for all users. And that policy then leads down into everything that they are doing to rethink how they're really addressing safety and turning a little bit away from speed, which is great. I told you our agency redid our strategic plan, and you can see one of our goals actually mentions the safe system approach as how we're going to be looking at the lens for how we manage the office and assign our funding. You'll also notice goal 1 is about proactive traffic safety culture. And we've been working on traffic safety culture since 2015. It is a framework, and we're molding it to work for us. So traffic safety culture is that shared beliefs about our individual actions that impact safety. And proactive traffic safety culture takes that another step and refers to our individual responsibility to create a safe road system for everyone. So looking about not just keeping myself safe, but making sure my family's safe, the people I work with are safe, the people I interact with, and my community is also safe. So in the proactive traffic safety culture framework, this is the really simple version, and why we're using it is it's used to understand why people behave the way they do. So we know that in this orangey circle right here, that people take actions that are proactive, that prevent crashes, and that also people make risky decisions that end up impacting crashes. And that is really their behavior that we are always working on as a behavioral traffic safety organization on how we can change. So the model really shows us that the behavior is a result of our values, our attitudes, and our beliefs, and then our willingness and intention to do something. That results in our behavior, which then results in how we're doing on our traffic safety numbers, which in Washington have been increasing in a very distressing way. That simple framework looks like this when it gets really complicated. And I'm just going to throw this up here so you can see kind of here's the values. These are types of beliefs: behavioral beliefs, normative beliefs, control beliefs. They result in attitudes, perceived norms, perceived control, which here again hits the willingness and intention, which really ends up being the behavior. The thing that I have loved most about this model is that it's really taken us from a place where we're guessing about whether or not what we're doing is effective, to a place where we can start measuring those things that have to happen first before we see the behavioral change. And that gives us a better pulse on our effectiveness. So excited. This year, we managed to do a very large traffic safety culture survey. More than 10,000, 11,000 surveys were completed. It was 104 question surveys. We used both address-based sampling and then complemented that with online panels to make sure that we were getting a good representation of all of our states' demographics. We conducted the survey in both English and Spanish, and Max, who you're going to hear from next, has done an amazing job getting all of these answers up on dashboards for us. There's a link for the dashboard. Basically, you go to our website, you hit data, and then you can find the dashboards pretty easily. And this one's the statewide traffic safety culture survey. You can see, you may not be able to read this dashboard as it is right now, but you can see on here, there are toggles. So you can look at this data by county, by gender, by age, race, ethnicity, education, employment status, household income, veteran status. And so as you toggle back and forth, all of these change, so you can really see how people answered. This road user behavior is one of 6 dashboards that are out there. We also have dashboards that talk about, risk perceptions, enforcement attitudes, bystander intervention, family and employer rules, and then one that shows the demographics of the people who took the survey. So it's fascinating. And I'm just going to walk through how we're using this survey in our programming. So right here at this behavior point of that big complicated model is the resultant behavior. So we ask people about their behavior in all aspects of traffic safety, but I'm sharing with you the ones about driving under the influence. So during the past 12 months, have you driven a vehicle while you're under the influence of alcohol, cannabis, or alcohol and cannabis? And you can see here 93.19% of people told us that they had not driven under the influence in the last 12 months, which is a really huge, great majority of people. But this 5% over here that tell us, yeah, we've driven impaired. They are causing an enormous amount of havoc and catastrophe on our roadways. So it's a small percentage, but it's a very important percentage to pay attention to. We see about the same percentages with cannabis, and slightly smaller, but still very concerning. People are telling us they're using both alcohol and cannabis and driving. So that's this behavior part. So what can we find out about why this behavior is happening? We ask a question about, in your opinion, so we're talking about beliefs, how often do most people in your community drive after consuming alcohol? And you'll remember in our previous slide, most people said they don't drive after using, 91%. But here we see that the people who answered our survey think that most people in their community drive after drinking, at least some of the time. Only 10% said never. So that is a perception that is a misperception, right? Most people are not driving after consuming alcohol, but in general, we perceive a world where driving after using alcohol is much more common than it is. If we believe it's more common, that's a perceived norm that can impact our willingness or behavior, our willingness and intention to drive after drinking, which then impacts our behavior of actually doing it. Another question we asked was, how dangerous do you feel the following behaviors are? So this is an attitude, a behavioral belief. If I think it's dangerous, I'm less likely to do it. If I don't think it's very dangerous, I'm more likely to do it. So driving shortly within an hour after consuming 1 drink of alcohol, 50% felt like that was very and extremely dangerous, but you can see we have a lot of work to do with the other half of the population, helping them see how impairment actually works. Driving shortly within an hour of consuming 2 or more drinks, even more people agreed that that was very or extremely dangerous, but still a lot of work we can do right here with this population. So how comfortable would it be for you to prevent someone who is too impaired from driving? And what we found with this answer is that people feel comfortable. They feel like that's something they should be doing. Deeper into the survey, they feel like that's something most people do. And that is really this piece of the controlled beliefs. We also asked them how often have they intervened with somebody who was too impaired to drive. And half of the people who said, yeah, I've been in that situation and I did something, 50% said, yeah, they took actions and they told us what they did. They got a taxi, they drove them home, they called for a safer ride, they let them stay. So that's been the kind of message that we can build that's not a fear-based message, but really a proactive traffic safety behavior of the problem with somebody who's impaired is they don't necessarily know they're impaired. So the people around them reaching out to prevent those impaired driving trips is a big, important part of this. So that's just a flavor of how we're working with these three pillars. I want to show you how it comes out in what we do. In this case, it's a campaign around bystander intervention. And let's see, we're going to stop this. If you give me just a second and go into the actual thing here. All right.
$3 pitcher night. A couple of cocktails.
Shelley, it's not showing.
And a nature documentary.
Thank you for letting me know. Why is it not showing? Oh, because I need to, sorry. So many buttons. All right, do you see the screen now?
We do not.
No? Okay. One more thing. All right, then let me know. Can you see it now? It looks like
We do. Thank you.
Okay. And then also let me know if you can hear it or not.
$3 pitcher night. A couple of cocktails. An edible. And a nature documentary. What do all these people have in common? A friend like you who offered a ride. Or made sure they got on a ride share. Or provided a couch to crash on. Thanks for keeping the roads a little safer tonight, Washington. Together, we get there.
Right. Thanks. You stopped sharing for me, right, Linda?
I did.
Okay. Excellent. So that's a taste of how we're thinking differently about traffic safety here, how we're baking it into.
Welcome to the pre-application webinar for Washington's Child Passengers.
Sorry. How we're baking it into all of the things that we do, all of the ways that we think about what we do, bringing our partners along with us. And I think that we're in a very exciting place in Washington. So thank you so much for your time. And I know we're going to go to questions at the end.
All right. Thank you very much, Shelley. Good afternoon, everyone. My name is Max Roberts, and I am the Senior Research Associate with the Washington Traffic Safety Commission. Thank you very much for having me here to speak. And today I will be sharing with you the novel approach and methods that we implemented here at the Traffic Safety Commission to update and improve our toxicology data, which allowed us to reevaluate the prevalence of polydrug driving in Washington. So let's begin by defining what we mean when we say polydrug positive. So a polydrug positive driver can fall into one of these two categories. First, they can be a driver that tests positive for 2 or more drugs that are not alcohol. So an example of this could be a driver that tests positive for THC and methamphetamine. And then second, they can be a driver that tests positive for alcohol and 1 or more other drugs. So for example, a driver that tests positive for both alcohol and THC. So polydrug really refers to any combination of two or more substances. And then although we say polydrug, it is important to note that polydrug can include alcohol. Since 2012, about half of all traffic fatalities in Washington involved an alcohol and/or drug-positive driver. And this is by far the most prevalent high-risk behavior we see on our roads, more than speeding, distraction, or not wearing a seatbelt. So this means that it is very important that we understand the drugs and alcohol involved in these fatal crashes. Now, I want to note that throughout the presentation, I use the terms alcohol and/or drug positive and also impairment interchangeably for the sake of simplicity. But although someone is positive for a drug, it does not necessarily mean that they were impaired by that drug. And that is a challenge for those of us working in impaired driving work. So while one person may be impaired by a drug at a concentration of 5 nanograms per milliliter, another person with 4 times that concentration may not show any signs of impairment at all. So with that said, and without leading the cart before the horse, part of what we're trying to do with this work is to have more confidence to say that these drivers were likely impaired by the drugs in their system. The data used for this analysis are our in-house fatal crash data, which are called the coded fatal crash or CFC files. And these data are compiled by our data analysts from police traffic collision reports, driver's license records, death certificates, and most importantly for this current work, our toxicology results, which we receive for every traffic fatality. Now, these toxicology results give us complete and reliable data to determine what drugs or alcohol were in the driver's system and what the concentrations of those were in the blood. But there can be risks in interpreting the raw toxicology results if you do not have some knowledge or understanding of the various drugs and metabolites that appear in these results. Now, I like to describe this work with an example. So imagine an older motorcycle rider getting ready to go on a ride on a Sunday morning. Let's say they woke up with some back pain, so they took a recommended dose of ibuprofen. Let's say they have a couple cups of coffee with their breakfast. They take their prescription medication, diltiazem, to help with their high blood pressure. And let's also say, for the sake of example, that this person is a chronic cannabis user, but they did not consume any cannabis the day before they went on their ride. So this individual sets off. Eventually, they get into a crash. They sustain serious injuries, and they are transported to a nearby hospital where they are administered midazolam, also known as Versed, prior to surgery, but they ultimately succumb to their injuries, and shortly thereafter, they die. So the toxicology results show that this person was positive for 5 different substances. They tested positive for the caffeine from the coffee that they drank that morning. They tested positive for carboxy-THC, which is the non-active metabolite of THC due to their chronic use of cannabis. They tested positive for their prescription medication diltiazem. They tested positive for the ibuprofen they took for their back pain. And they tested positive for the midazolam that was administered post-crash by hospital staff. So previously, this case would have been flagged in our data as a polydrug positive driver. And looking at the data, we would presume that drug impairment contributed to the fatal crash. However, none of these substances have impairing qualities that contributed to or were directly involved in the crash. So in fact, if we were to remove all of these non-impairing or unrelated substances, we would determine that this fatal crash did not actually involve drugs or impairment at all. And that is what we aim to do with this work, is to eliminate or reduce instances of non-impairing or unrelated drugs and substances, thereby improving the quality and accuracy of our drug-positive driver data. So we did this by implementing the following steps in our drug data. We removed non-impairing and unrelated substances, such as the ibuprofen, caffeine, and midazolam in the example. We removed non-impairing metabolites when the parent drug was absent, such as the carboxy-THC in the motorcycle rider's system. And we removed non-impairing pharmaceutical drugs when alcohol was absent. We matched parent drugs with their metabolites, and we removed toxicology screening results when confirmatory results were present. So one of the first steps in this process was removing non-impairing and unrelated substances. So the list of drugs and substances here were screened out and removed from our drug data. We determined that these drugs and substances were non-impairing, and some of them were more obvious than others. Some of these were health supplements, such as yohimbine and tadalafil. Some of them were antibiotics. I know that one of them was an anti-malarial treatment. Others were organic compounds formed in the body, such as glucose and ketones, which are commonly seen among diabetics. We had nicotine and its metabolite cotinine. We had naloxone, which is used to reverse opioid overdoses. Theobromine, which is a byproduct of chocolate. We had acetaminophen and ibuprofen, which are both over-the-counter pain relievers. We had midazolam and etomidate, which are usually administered post-crash by EMS responders and in hospital settings. And then we had something called carboxyhemoglobin, which actually results from carbon monoxide exposure. So this was appearing in a lot of our cases that involved vehicle fires. So we wanted to be sure that none of these non-impairing or unrelated drugs were causing any drivers in our data to be flagged as drug positive or impaired. The next step was removing non-active metabolites when the parent drug was absent. So when a drug is metabolized in the body, it can produce either an active or a non-active metabolite. An active metabolite can begin or continue to have effects on the body. So this would be the case with codeine, for example. And when the body metabolizes it, it becomes morphine. A non-active metabolite is a metabolite that does not have any effect on the body. So this would be the case of carboxy-THC when the body metabolizes delta-9-THC. And the metabolites listed here were removed if the parent drug was absent. So if an individual tested positive for carboxy-THC and its parent drug delta-9-THC was absent, it would be removed. However, we did not remove metabolites regardless of their activity status if the parent drug was present. And that is because in those circumstances where a parent drug and metabolite were present, we matched them together, which was the next step in the process. So as we can see in this example, prior to the updates, if a person was positive for the parent drug delta-9-THC and its metabolite carboxy-THC, each were counted as a separate drug, and therefore this person was flagged as polydrug positive. So you can see how this could be problematic. If we have several people that consumed only one drug and the body metabolizes those parent drugs into one or more metabolites, suddenly we have several polydrug positive people when in fact they only consumed one drug. So this is where it can be risky interpreting the raw toxicology data, because if you are not aware of the parent metabolite relationship between the drugs and the toxicology results, then you can risk counting drug metabolites as separate impairing drugs. So this risks artificially inflating our polydrug positive driver counts. So by matching the parent drug with their metabolite, we created the parent metabolite compound delta-9-THC carboxy-THC, which is then counted as a single drug. So by combining the parent drugs with their metabolites, we can determine situations where actually only one drug was consumed. And we have a more reliable grasp on the prevalence of polydrug versus one drug impairment. So as part of this step, we created several parent metabolite compounds, such as delta-9-THC, carboxy-THC, methamphetamine, amphetamine, and fentanyl, norfentanyl. Most parent drugs had a single metabolite, but there were several circumstances where a parent drug had multiple metabolites. So for example, cocaine has 3 different metabolites, and they are benzoylecgonine and ecgonine methyl ester, which are both non-active metabolites. And then there's cocaethylene, which is an active metabolite from the combination of cocaine and alcohol. So we made unique parent metabolite compounds for all possible scenarios, including scenarios where multiple metabolites were present. So in the case of cocaine, for example, there were 4 different unique cocaine metabolite combinations. Next, we removed non-impairing pharmaceutical drugs, but only if alcohol was absent. And this is because there could be potential for these drugs to interact with the alcohol, which would then cause them to have impairing effects. So the list here shows those pharmaceuticals that we deem to be non-impairing. Some of these non-impairing pharmaceuticals are calcium channel blockers, which generally target the cardiovascular system and can be used in treatment of high blood pressure. We also had several anticonvulsants, anticoagulants, antipsychotics, and then decongestants. And an important consideration with this work is that a lot of people take pharmaceutical medication. And according to the Health Policy Institute at Georgetown University, nearly 2/3 of American adults use prescription drugs. More often than not, these drugs do not impair one's ability to drive. And in many situations, these medications are needed to allow a person to go about their daily activities in a safe and healthful way. Some pharmaceutical drugs can even improve a person's ability to drive compared to if they were not taking their prescribed medication to treat an underlying condition. The next step was identifying screening versus confirmatory toxicology results. And this was something more applicable to older years of our toxicology data, but others interested in this work should check their own toxicology data for these sorts of scenarios. So a screening test can be used in a toxicology panel to determine if a type of drug is present in the blood sample, whereas a confirmatory test can be used to determine if a specific drug is present and what the concentration of that drug is in the blood. Now, in some circumstances, both a screening and confirmatory result present in the toxicology results, which means that each was being counted as a separate drug, sort of like the parent drugs and their metabolites. In the top example, we have a situation where a driver had a positive screening result for cannabinoids and a positive confirmatory result for delta-9 THC carboxy THC. So this driver would have been flagged as a polydrug positive driver. We would want to remove that screening result in this example since we have the confirmatory result. So this would change their status from polydrug to one drug positive. And then same for the example on the bottom. This driver was positive for codeine, opiates, and oxycodone. And since we have the confirmatory results, which are codeine and oxycodone, we would remove the positive screening result for opiates. Now, this driver would still be polydrug positive because they had 2 different drugs in their system, but the number of drugs is reduced from 3 to 2 when we remove the screening result. Okay, now we can get into some of the data and see how it changed after we implemented these updates. And just so I don't need to be too repetitive, these data will all be from 2012 to 2021 and will be restricted to drivers involved in fatal crashes. So prior to the updates, we had a total of 2,549 alcohol and/or drug positive drivers involved in fatal crashes in Washington. After implementing these changes, we saw a 6% reduction in this number down to 2,397. Now, these figures include both drug and alcohol results, but if we were to exclude alcohol and just focus on drivers positive for drugs, we see that this change is even greater. So before the updates, we had 1,875 drivers in fatal crashes that were positive for just drugs, no alcohol. And after we implemented the updates, this number decreased by 17% down to 1,605. And this reduction is a result of removing several of those non-impairing and unrelated substances. So several of those drivers that were positive for carboxyhemoglobin and nothing else, drivers that were positive for caffeine or acetaminophen or ibuprofen and nothing else, or drivers that were positive for antibiotics or only carboxy-THC. And all those drivers that were previously drug positive for these non-impairing or unrelated drugs were removed. Here we see the trends in the number of drivers and fatal crashes positive for alcohol and or drugs by different impairment types. And those different types are alcohol only, which is the blue line in the middle, one drug only, which is the orange line near the bottom, and then polydrug, including 2 or more drugs or a combination of alcohol and drugs, which is the green line at the top. And we can see that the number of drivers and fatal crashes positive for one drug only and alcohol only has remained relatively stable over time, with one drug being the lowest category. Conversely, the number of drivers and fatal crashes that are polydrug positive has been increasing rapidly since 2012, reaching a high of 221 in 2021. Now, after we implemented these updates to our data, this is how the pattern shifted. We found that the increase in polydrug drivers since 2012 was still very real, and it remains the most prevalent category of impaired drivers in recent years. Alcohol-only cases increased slightly across all years, but we found a larger increase in one-drug drivers in every year. So what we see is this sort of convergence between the polydrug group and the one-drug group compared to the older trends. And what is actually happening is a reclassification of drivers from the polydrug category to the one-drug category. So where we previously had a polydrug positive driver, positive for delta-9 THC and the metabolite carboxy-THC, we now have just a single parent metabolite drug compound. And so that person became a one-drug positive driver. So looking at 2021, one drug positive drivers were more prevalent on our roads than we previously thought, but polydrug positive drivers were still the most prevalent group, and we saw a big increase in polydrug positive drivers in 2021. Now here we can see the change in the number of drugs present among our drug positive drivers and fatal crashes. And please note that this chart does now exclude alcohol, so we are only looking at drug positive. Before the updates, more than 1/3 of drug positive drivers, or 37%, had 2 drugs in their system. 18% had 3 drugs, 22% had 4 or more drugs, and 23%, nearly 1 in 4, had only 1 drug in their system. Now, after the updates, we saw quite a shift. The majority, or 62%, were positive for only 1 drug. 23% were positive for 2 drugs, 9% were positive for 3 drugs, and 6% were positive for 4 or more drugs. So again, we see this shift where many of those metabolites were matched with their parent drugs to produce a single drug compound, or other non-impairing drugs were removed to decrease the overall number of drugs on board. Here we have the top 20 most common drug and alcohol combinations among drivers and fatal crashes. So you will notice that alcohol is now included again with all of our drug results. Alcohol alone sits at the top of the list, representing 33% of drivers and fatal crashes, which is to say that 1/3 of impaired drivers and fatal crashes were positive for alcohol alone. Next, we saw alcohol and delta-9 THC carboxy-THC, which represented 10% of drivers. Then we had delta-9 THC carboxy-THC alone at 8%, and then we had methamphetamine, amphetamine at 5%. And if you keep going down the list, you will mostly see various combinations of alcohol, THC, and methamphetamine. Nearly 56% of our impaired drivers had some combination of alcohol and or Delta-9 THC without any other drugs present. And the top 20 drug alcohol combinations that you see here account for nearly 70% of all drug and alcohol positive drivers involved in fatal crashes. So the remaining 30% that are not shown here are mostly unique one-off combinations such as cocaine with alcohol, with fentanyl, with THC, with oxycodone. Now this chart shows the prevalence of alcohol and select drugs among impaired drivers in fatal crashes. So this includes all drug and or alcohol positive drivers. So of all those drivers, we see that 60% tested positive for any alcohol, whether alone or in combination with drugs. 1/3 of impaired drivers had at least Delta-9 THC on board. 17% had at least methamphetamine on board. Nearly 3% had at least citalopram on board, and less than 2% had fentanyl on board. So this obviously is not a comprehensive list, but it includes some of the most common drugs that popped up in our toxicology data, with the exception of fentanyl. And although fentanyl was not a top drug in our data, I included it because we have a serious fentanyl problem in Washington, as is the case in many other states, but we are not seeing it reflected in our drug positive driver data necessarily. Only a very small proportion of drivers have fentanyl in their system, and there's also a chance that some of these cases are cases where it was administered in a hospital setting post-crash. Now, this chart really highlights that although we are seeing more polydrug positive drivers on our roads, alcohol remains the biggest perpetrator for impaired driving in Washington, followed by THC and then methamphetamine. So I will say that we can't take our foot off the gas to prevent drunk driving, and it must continue to be a priority to eliminate alcohol from our roadways. Now here we can see differences in the prevalence of different impairment types between males and females. So it's likely no surprise, but males represented nearly 4 out of 5 impaired drivers. The most prevalent impairment type among males was polydrug, which are the blue bars at the bottom, representing 40% of impaired male drivers. The next most prevalent impairment type was alcohol only, which is the green bar at the top at 36%. And then one drug only, which is the orange bar in the middle at 24%. And among females, nearly half of impaired drivers were polydrug positive, followed by 28% that were positive for one drug only, and 23% that were positive for alcohol only. So interestingly, we see that polydrug was much more prevalent in females compared to males. And here we can see the prevalence of the different impairment types across age groups among impaired drivers in fatal crashes. So we see that polydrug, the blue bars to the far right, was most prevalent among all ages under 66, and especially those ages 26 to 35, 36 to 45, and 56 to 65. Alcohol only, which are the green bars to the far left, was most prevalent among those under the age of 56. And the prevalence of alcohol only decreased at ages 56, 66, and then was lowest amongst those ages 76 plus. And then lastly, one drug only, the orange bars in the middle, was most prevalent among the oldest age groups, 66 to 75 and 76 plus. So we might expect that older ages are most likely to be taking one or more prescription drugs, which may be reflected in the proportion of one drug and polydrug that we see here. Next, we have a breakdown of the impairment types across different days of the week. So it should come as no surprise that we see more alcohol only, which are the green bars at the top, occurring on the weekends from Friday through Sunday, and then less so on the weekdays. We can see on Saturday and Sunday, both had 42% of impaired drivers that were positive for alcohol only. We see slightly more polydrug prevalence, which are the blue bars at the bottom, during the weekdays, and then same for one drug only, which are the orange bars in the middle. We see the most prevalence of polydrug on Tuesdays at 45%, followed by Thursdays at 44%, and then Wednesdays at 43%. So this sort of paints a picture of the types of users using which drugs and alcohol and when they're using them. And then lastly, here we have the impairment types broken out by time of day. So polydrug, the blue bars on the far right, was relatively consistent throughout the day, but we see a notable difference between alcohol only and one drug only. So alcohol only, again, not likely a surprise, but it was more prevalent in the evenings and early mornings, pretty much between 6 p.m. and 6 a.m. And then from midnight to 3 a.m., alcohol only is most prevalent, representing nearly half of all impaired drivers. And then we see sort of the opposite for one drug only, where we see a peak of one drug only drivers in the middle of the day from 6 a.m. to 6 p.m., and much less so in the evenings and early mornings. So we see the greatest prevalence of one drug only between 9 a.m. and noon at 42%, followed by noon and 3 p.m. at 41%. So I want to wrap up by touching on some limitations and opportunities for future work on this topic. So one important limitation with any drug work is the length of time between the crash and a blood draw. So as I mentioned, drugs can be quickly metabolized in the body. So if there are several hours between the time of the crash and a blood draw, the concentration of the drugs in the driver's system may decrease to undetectable levels, or may have already been metabolized or not appear as an active impairing drug in their system. So this can have implications for DUI adjudication as well. But the sooner that you can get a blood draw after a crash, the more accurate the concentration of the drugs in the blood can be detected at the time of the crash. There's also a limitation with data linkages between EMS, hospital data, and our toxicology data. So it is important to record and link hospital and EMS data to flag drugs that were administered by emergency staff so that those are not marked as drugs present at the time of the crash. So we get some of these records, but comprehensive linkages would be needed to assure those cases of emergency treatment are not being counted towards our impaired driver data. Next, we have the introduction of new illicit and pharmaceutical drugs. There are new drugs hitting the streets and the markets all the time. So this work will require ongoing updates and assessment to our potentially impairing drug list and which drugs we retain or exclude from our data. And this means that there needs to be an ongoing effort to assess how drugs affect driving abilities. A major challenge of this work was the lack of comprehensive simulated studies on how every drug affects driving ability. So some things like THC and alcohol have plenty of research around their effects on driving. Other broad drug categories like benzodiazepines also have research documenting their effects on driving. But in more cases than not, there was a lack of tested effects of drugs on driving ability. So therefore, more research is needed so we can have a better understanding of drug impairment and driving. So I just want to close by acknowledging that this is a novel approach to this work, and other states, other jurisdictions may have a different approach than us, but we welcome discussions about this work because we think it's important and valuable to understand the prevalence of certain drugs and impairment types so we can administer the most appropriate countermeasures and interventions. I just want to share these QR codes. The QR code on the left is our drug positive driver data update. So this is a few pages. It's a brief. It's meant to just give a high level overview of everything that I talked about here. The QR code to the right, this is the full report that we completed that's available on our website, which will include all the details that I shared here and much more. These slides have also been shared with the communication team, and I believe that they will be available on the website sometime within the next 24 hours. So thank you very much.
Great, thank you both to Shelley and Max for those great presentations. We do have some questions in our Q&A section that I can read, but I'll encourage everyone else to also continue to submit your questions there, and we can get to a few of them. So I can start off with the questions that have been submitted. The first question from Howard Preston is, do Washington State Police crash reports include the ethnicity of those involved?
You want to go, Max?
If you can take the lead,
Okay.
and then I can follow up.
So in our coded crash files, we get race and ethnicity data from death certificates.
Yep, that's it.
All right, good. Short answer.
We agree.
The next we have from Christine Hernandez. Shelley, could you please talk about some of the legislation that Washington is trying to get passed, or any new legislation that did pass? And Christine gave the example of lowering BAC to 0.04, for example, and why those decisions were made.
I love to talk about legislation. Thanks for that question. Yeah, so we have been, there's been legislation introduced for at least the last 3 years to lower our per se BAC level from 0.08 to 0.05. 0.04 may make, I'd be happy if it was lower. 0.04 is what we tell commercial drivers they can have. So yeah, I think National Safety Council has been, I'm sorry, not the National, the NTSB has been pushing this countermeasure out to states for 10 years. Utah was brave and passed a law in 2017 that became effective 2019. And the results from that looked great. They experienced, in their surveys, they experienced a lot of people who told them that the law had caused them to change their behaviors around drinking and driving. So they were planning ahead, they weren't driving after drinking, which is really what a 0.05 law is about. It hasn't passed yet. It's in both houses right now. It's in rules in the Senate, and we're having a committee hearing in the House on it tomorrow. I'm very excited for another chance to educate members about why and how and what about 0.05. We're doing it because in Washington, we've done a lot around traffic safety, but this is a very important tool that we are not employing at a time when we're seeing increasing traffic fatalities, highs that we haven't seen since I think the 80s for 2023. Horrifying for those families that never get over the loss of that loved one's life. And I think as a traffic safety office, we have it in our responsibility to continue to put out those effective countermeasures that are being left on the table. Other legislative areas that we've been working in that's been really exciting is use of traffic safety cameras. So last year, a couple of things happened. The first one was they passed legislation to allow traffic safety cameras in freeway work zones. They were very passionate about why and protecting those people that are trying to make our transportation system work from people speeding through the site. They're looking at a technical fix to that bill this year. I think it'll be fine. I think that'll go through. In the past few years, we've really expanded our use of traffic safety cameras. It was just school zones and then, red light cameras at intersections. So in the past few years, we've expanded that to be hospital zones, park zones, the entire school walk route. And then local jurisdictions can employ them in areas where they have problems, right? So they are using it based on the data. So it's really exciting that we've had that increase. We've been hearing from cities and counties that there was some confusion and some reluctance to take on the new types of cameras. So we've introduced a bill this year to kind of clarify some of that. And to make some small changes that mean like the whole funding from traffic safety cameras goes to the city or the county instead of some of it coming to the state. Hoping that makes it a little sweeter for cities and counties to use these. It does stipulate that any revenue from these cameras has to go to improving traffic safety. Hopefully coming along after cameras there with an engineering fix that will permanently solve the problem, like a roundabout. I'm just saying. So we hope that that one also will pass, just so we have clarity. The big news that we've been looking at lately has come from the pedestrian evaluation that our DOT did, and they're really looking at these, what they call stroads. So those roads that used to connect communities that are now, they used to be high speed or higher speeds, and now they're surrounded by commercial and apartments and everything else that wasn't there 20 years ago or 30 years ago. That those are really dangerous areas for pedestrians, and those are areas we'd like to clarify that local jurisdictions can use cameras on. So we're right in the middle of session. This is
So it's an exciting time, right?
exciting time.
Great. Thank you for that. There was a question from Sean Carlson, and just mentioning, hopefully this wasn't already covered, but what about other deltas such as 8 and 10?
Yeah, thanks for that question. And no, it was not covered. It really depends on the testing lab and whether or not they're testing for it. So we are very lucky to have a central toxicology testing lab that is overseen by our Washington State Patrol office. And they just recently opened a second location. We do send some testing out to NMS Labs, which I believe is based in Pennsylvania, but generally they follow the same criteria for detection levels. And the Delta 8s and Delta 10s, these are new synthetic cannabinoids that are out on some markets that are not regulated and are available for purchase, where otherwise Delta 9 THC is still illegal. So there's a legality status to it. So in some circumstances, we're not seeing those tests conducted. These are things that have really grown in popularity and are emerging in recent years. But with that being said, the things that we have seen popped up in our toxicology data are synthetic cannabinoids. So I think that is the broad umbrella term that is referring to those non-Delta 9 THC cannabinoid alternatives. And those numbers are very small. I think in this 10 years of data, I only had 3 circumstances of synthetic cannabinoids popping up in our toxicology results. And those were pretty much within the last 3 or 4 years. So more research is needed into that, but as other jurisdictions are looking into this, look at the tests that are being conducted in your local toxicology labs and see if that is something on the panel that is being tested for.
Great, thank you. How is or will, Max, your presentation data influence messaging around impaired driving? For example, do you focus most heavily on alcohol and cannabis consumption, or would you focus on broad impaired messaging to reflect the dangers of any impairing substance?
Great question. Yes, I think both of those are very important. And I think clearly, as I presented, I think our focus and emphasis should still continue to be on alcohol and THC, and then to a lesser extent, these other drug combinations. The polydrug prevalence that we do see, a lot of it is commonly alcohol and THC. So promoting messages that are surrounding the risks involved with taking both of these substances together, and making sure that people understand that it's really not safe. Other things, we have a lot of prescription medications that are popping up. So something that seems like low-hanging fruit for me is making sure that doctors' offices are communicating the potential risks of impairment when taking these medications, not combining these medications with alcohol, and making sure that that's also going through our pharmacies as well when people are picking up medication, and making sure that that is verbally communicated. Oftentimes it will be labeled on the packaging of the prescription medication, making sure there is compliance with that in various jurisdictions and states. But yeah, I think certainly emphasizing our efforts on alcohol and THC for sure.
Thank you. There's also a suggestion that you present at Lifesavers in Denver, Max. Your presentation is fascinating, so you got a plug there.
Thank you very much.
Here's a question from Lauren Hill about driver involved. If a two-vehicle crash where a drunk driver is stopped legally for a red light and gets hit by a completely sober driver, are both drivers included in your stats? Have you considered looking at only single vehicle crashes?
Yes, that could definitely be a next step in some of this analysis that we're doing. There's 100 different ways that we can splice this data. My mind's going crazy with all the different ways that I want to expand this and drill down and look at some of these different drug combinations. We like to call that the innocent drunk or the innocent impaired driver who is going about their business and happens to find themselves in a crash that was not of any cause of their own, even though they should not have been operating a vehicle while impaired. Both of those would be included in our stats. Everything that I spoke to today would only be looking at the data revolving around that driver that was drunk, however. So that other sober driver who wasn't tested, didn't show any signs of impairment, they would not be included with the impaired driver data that I discussed today.
Okay. And have you looked at where crashes involving drugs and alcohol are occurring by road type, such as state versus local system?
Yes, that is another next step. We do have several dashboards on our website, as Shelley alluded to earlier, one of which is an impairment dashboard, which shows our impaired driver involved fatalities. And we have a crash level page that does map where all of those different crashes occurred. You can also use various filters to look at alcohol only impaired drivers where they crashed, THC positive only drivers where they crashed, polydrug, no alcohol, polydrug with alcohol, one drug only. So yes, we do have that data available. I could see if I could pull it up and maybe drop it into the chat for everyone.
Great, thank you. I have a question for Shelley. In your presentation, you mentioned this risk perception that exists and this kind of mismatch between what people think is happening and what's actually happening. And I know if you had the answer, you'd be a millionaire, but I'm going to ask it anyway. How do we change that? I mean, I think that's a challenge in so many areas of public health and all sorts of other aspects of life. But how do we get that more on track so that people understand what's really going on so that they can use that information for their own safety and well-being?
So a long-standing public health approach to misperceptions is to correct them. So you just show the data. This is the number of people in this high school who say they're buckling up. And this is the number of people you think are buckling up. Guess what? More of you are buckling up. Those just that data itself is enough to start curbing behavior, because we are social beings and we want to be doing what is expected of us. We're more likely not to wear a seatbelt if we've been seeing lots of people not wear their seatbelt, or if we believe that lots of people don't wear their seatbelt. But once we figure out that, most of us 95% are wearing our seatbelts all the time, it does make you recognize that you're an outlier and you can move towards that better piece. And I think a lot of what we've been working on in Washington is really that bystander intervention. So not only do most of us wear our seatbelts, most of us say something to someone who's not, because the people who have risky traffic behaviors are hard to reach in messaging. They're more messaging outreach is more segmented than ever. And we know that the best messaging is going to come from family, coworkers, and friends. So the more we can encourage family rules, workplace rules, discussions about it, the more successful I think we'll be at reaching those risky behaviors than anything else.
And so I guess that fits in well with that kind of positive messaging that you're encouraging too, is the fact is most people are not driving impaired. So to continue those types of messages, I guess it does kind of fit nicely.
Yeah. Yeah, that's why I love the behavioral model, is because I have a place between what we might be doing, whether it's messaging or how we're running a program, and, you know, the result that we'll see on our roadways. There's these other things that have to change first, and we can measure those now. So it's really exciting.
Yeah, it is. It is. Max, I have a question for you too, and I'll encourage people to keep adding their questions in the Q&A section, if there are folks in the audience that still have questions. So I'm with the Department of Health, and so we have a public health lab, and they do a lot of drug testing, and we see numbers for polysubstance use that are, you know, increasing dramatically. And I have lots of notes to go back and talk to my colleagues in the public health lab to learn more about what they're doing. But with this new kind of model that you've developed, is that happening in, say, your public health lab across other spaces where they're reporting on polysubstance use?
That is an excellent question. And I have not had those conversations yet, but yeah, absolutely. Something worth considering in other accidents, other sorts of injury situations that we're looking at. Yeah, I think that's a very valid thing to look at and be considerate of. You know, given exactly the examples that I'm showing here, that they ultimately might be unrelated or not directly related in the sequence of events that led up to the accident.
Mm-hmm. Yeah. Yeah, it'll be interesting as time goes on and these numbers get adjusted, and we see what the narrative ends up being. So that's great. I'll put a call out. Let's see, I think perhaps another question was just submitted here. Oh, we've got a couple more. So have you been working on getting people to retake their driver's license tests if they receive a citation, or tying citations to income to address economic disparities?
Yeah, interesting. So last year, or I think the year before, the legislature passed some loosening of laws, traffic laws, but they also supplemented that with a new approach that says if you get 3 traffic tickets in 1 year, you have to actually be re-educated. You have to go to an education piece before you can get your license back. That's certainly great. It's also 4 offenses in 2 years. So hopefully that'll start seeing more chance to educate drivers about what's safe and why what they're doing is dangerous. Day fines is something we talk about here a lot. I was part of a contingent of Washingtonians who went to Finland to look at how they do traffic. We started about the same place 20 years ago, and now they're experiencing huge decreases while we're experiencing increases. And they do have what they call a day fine. So traffic tickets, especially something like impaired driving, get put through a formula that says this is how much you make in a month, and therefore this is how much your fine is going to be. So that fines hurt everybody at an equal pressure point, right?
Mm-hmm.
Not just like, well, I don't care. I make money driving in the express lanes or speeding. My time's worth more than that $175 ticket or whatever. So in Finland, they have fines that go up to about, well, they were saying hundreds of thousands of dollars, depending on what someone's situation is.
Wow.
So I love that idea. And we talk about it as much as we can. I can't say it's in legislation right now, though.
Right, great. So there's one last question, and maybe we'll just ask for a quick answer before we wrap this up. But is there a mechanism in Washington to share this data with the judges who handle cases involving impaired driving?
Yeah, I think we definitely have some communication opportunities. We have several committees and working groups where we work with law enforcement liaisons, resource prosecutors, various people at the adjudication level. So yeah, I think there's certainly points of access to communicate this information to.
Great. Wonderful. Well, it's 2:14, so we're going to meet our time, right on the dot. I'd like to thank everyone for attending and thank our speakers for being here and sharing their great work. And I think inspiring a lot of good, thoughtful questions and discussion. Our next Hotdish is going to be April 3rd at 10 a.m. and 6 states will reveal their recent recreational vehicle safety campaigns. So we look forward to that. Thank you all for being here and have a great day.
Thanks, everyone.
Thanks, everyone.